All right. We will go ahead and get started. So if you are new to the clinical athlete community, or this is your first journal club, welcome. And as far as participation, you always have a few options. You can join in the discussion. So this is kind of it's a organic discussion, and it's very informal. And if you have thoughts, comments, questions, feel free to jump in. We'll say if you do want to do that, type the word question into the chat and we'll prompt you to unmute yourself and join in. But we're also not going to kick you out if you just unmute yourself and start talking. It's a relatively small enough group where you can just do that. But we definitely want your thoughts, especially with the topic tonight of returning to exercise after COVID. If any of you had experienced that with your athletes or personally, that would be great to have as discussion points. And obviously you can just join in and listen in and be an active listener. If you'd rather not speak, let us hear your voice or show your face, but you still have a comment, question that you want us to discuss, you can throw that in the chat as well. And otherwise, just use the chat as kind of open side discussion, like you would do in any live Facebook or YouTube event or something like that. So feel free to drop resources in the chat based on what we're talking about, or any side discussions that you want. These meetings are always open to anyone who want to join in. So if you have any colleagues that would want to do these in the future, make sure you let them know that we have these, and then we do them frequently. I'm going to drop the paper links in the chat. So just in case you hadn't had a chance to download those, these are going to go straight to the PDFs. And just give me a second here. So that's the first one. Here's the second link. Papow. These are short papers. So to contrast the last few weeks where we've had longer papers, these ones were short, quick reads, probably because we don't know a whole lot about the topic. But if you hadn't had a chance to download them or read them, they are in the chat. And just a quick note on sound, if you had unmuted yourself and joined the discussion, but then later on you're not talking, just try to remember to mute yourself again so any background noise doesn't come through. With all of that said, welcome to the Clinical Athlete Journal Club number 34. My name is Quinn Hennick. I am a proud clinical athlete provider, and I'm joined this week by Kevin McNamara. Kevin is back. We missed him last week. He's a physical therapist in the Seattle area. He's a longtime Clinical Athlete Forum member and the one responsible for bringing the Journal Club to life. Kevin, what's up, man?
Not much, Quinn. How are you?
I'm doing well. I'm glad to see that you're back and also that your audio works. And
I got the mic today.
I'm ready. It's going to be a good day. We are also joined by Clinical Athlete Journal Club intern Megan Broussard, who's a student PT down in Texas at UT Southwestern. Welcome, Megan. Say hi.
Hey, guys.
Megan organizes these things. She keeps us all in line. She makes sure that they run smoothly and seamlessly. So we all give her a thanks if you see her on the gram or in person one of these days when we still see people in person. And lastly, if you're curious about the background and the motivation for these meetings, as we do with all of our meetings, a smart guy named Benjamin Franklin way back in the day started a weekly club, and they called it the Junto Club, and it was a mutual improvement club, and basically a room of just really smart people explaining or talking through all the issues of the day. And they had an important policy for their meetings, which we have adopted as a Clinical Athlete Journal Club motto. And that is, these meetings are conducted in the sincere spirit of inquiry after truth without fondness of dispute or desire of victory. We encourage discussion, but we're all on the same team and we're just trying to be less wrong. Okay. Tonight's topic is return to exercise after COVID-19. And we've got those two papers that we're going to dig into, but let's get a feel for the room here. If you got a second, answer that poll that just popped up in front of you. Are you a clinician, a student clinician, a coach trainer, or a student coach trainer? Just so we can get a feel for the demographic. We've had some more clinical topics, seems like recently. So the clinicians have been dominating. We've got some coaches and student coaches. That's good. So I'll share that so you guys can see. Mostly clinicians, student clinicians, but a good, decent mix today. So our two papers are, again, the topic was return to exercise after COVID diagnosis. And our two papers, if I can pull them up in front of me. There we go. They are review papers and viewpoint papers. So we're not looking at studies. We're looking at papers that are kind of trying to explain and summarize the current evidence on a particular topic. So they tend to read a little faster, a little bit more like a narrative. And the first paper was titled A Game Plan for the Resumption of Sport and Exercise After Coronavirus Disease 2019 Infection. And the second paper was Considerations for Return to Exercise Following Mild to Moderate COVID-19 in the rec athlete. And both papers kind of go into how COVID-19 can be kind of a multi-system illness, and it can affect multiple systems, primarily pulmonary, but secondarily cardiac system and other systems down the line. And I think we'll probably just kind of dig into what's tangible, which is recommendations of coming back after illness. And I'll just defer to the group right away and say, if you have experiences with your athletes or yourself, please jump right in. I was trying to think between March when all this started and now, I've not actually dealt with an athlete directly after they were symptomatic. So I wasn't a person, I haven't been a person that's like their first line of defense getting back into exercise, which surprisingly enough, if any athletes had COVID, it was weeks or multiple months before they started to work with me, and or they just haven't been symptomatic. So I don't have that experience. So if any of you guys do, please chime in. But what I was surprised at, not necessarily that the recommendations were as conservative as they were, because in general, it was, if you test positive, but you're not symptomatic, you should still quarantine for 2 weeks. And then no exercise. Recommendation was no physical activity for those 2 weeks, even if you're asymptomatic. And then after those 2 weeks, a graded exposure back to activity at 50% load, 50% reduction in load, 40%, 30%, 10%. So just a graded return. If you were symptomatic, but not hospitalized, some mild symptoms, that 2 week quarantine, plus another 7 days after your symptoms resolved, to start your graded exercise program. And then we increase, if you were hospitalized, we might go to myocarditis guidelines, which is more extensive cardiac testing, potentially a 3 to 6 month timeline of return to sport, these types of things. But I was thinking, man, one name that popped in my head, one of the professional athletes that has been in the news and got COVID, Lamar Jackson, the quarterback for the Baltimore Ravens. I dug into his timeline, and he tested positive on Thanksgiving night, which was the 26th of November. He played on December 8th. He played an NFL game 12 days later. So he tested positive. He played an NFL game 12 days later. That ain't no 50% reduction in load. And also he was symptomatic. So a lot of these athletes that are asymptomatic, Lamar Jackson said that he had all the symptoms. And so I just thought that was interesting with the kind of, when we think about that, like super high end multi-million-dollar athlete, and then the recommendations that are generally given, and the discrepancy there, just kind of depending on who we're talking about. But obviously most of us are not working with Lamar Jackson, but just a little bit of context. Digging into the chat's already blown up. Yeah, Alex. So Alex, this was your topic that you threw out into the forum. And you recently wrote a blog because one, you were digging into the literature, but because you got COVID and you're working back into things. So we'd definitely be interested in hearing your perspective.
Yeah, I saw also there's quite a few other people who said something similar and are at varying stages. So I'm very interested to hear from everyone else. One thing while you were talking about Lamar Jackson, and so what's interesting to me, and this is something that kind of came to fruition as I was going through some of the literature and just kind of thinking about it. So I presently work as a strength coach, but I am in PT school. So what's interesting is that you test positive for COVID and you are a non-professional athlete. The only recommendation that you really have is stay home first and foremost. So you don't have to go to your care provider. And if you're in the young, fit population with no pre-existing conditions, unless you go on an internet search, which can get very scary, there's no guarantee you're going to see your doctor. And so that's sort of where I started, because I just finished cardiopulmonary and I was like, this seems questionable to me that I should just go back to my regular exercise slowly. But then in talking about the Lamar Jackson kind of concept, it's like professional athletes, I imagine that they can return a little bit quicker because they can have they have the resources to do constant monitoring. And so they can kind of assess, all right, what is their cardiovascular status look like? What does their pulmonary status look like? What do they have? They can have an EKG every day of their quarantining period, and they can test every single day. And so I look at these two sides of the spectrum, and then I was wondering, like, what happens to all these other people who fall into that category of like, all right, they want to just go back to what they were doing before and they feel better. But then you go into the literature and there are some scary cases, many of which are one-off, but like people have died in their 30s who were young and healthy and had a mild case of COVID and then returned to exercise. So it really covered the gamut, and I'm curious what other people are seeing because it's all over the place.
Kevin, do you have any direct experience in the last couple months?
Most of my experience has been not more from like the strength and conditioning side, but more like post-rehab, particularly like post-operatively side. So, the thing with this is I don't want to come across as like ultra crepidarian, but I'll go out on a limb and say that I don't know how much it really changes management in terms of, what we're doing, kind of just resting on laurels of like good exercise prescription. And I don't like mean that as like a one-off, as to kind of like disregard this or kind of just, toss it aside. But I think for one, we don't really have a lot of data to kind of guide decision-making in terms of like, what are some of the longer term side effects? How prevalent is it in those populations? And, how many and what type of systems are involved? And I just don't think we have enough data to really kind of make strong decisions there. So to me, I think that just trying to kind of go by what is being put forth as sort of a broad stroke recommendation in terms of, taking the 2-week rest, going by CDC guidelines, whatever sort of organizational body that you're going by, and then just kind of resting on our, general principles of good exercise prescription seem to be kind of the best way to go about it in my mind, just because I don't feel like we have enough information to really stand firmly in providing true recommendations. And then I think as we get more data, whether that's, observational or longitudinal, whatever it is, that will probably change. But I just don't know how strong we should make some of the recommendations that we are, just going off of some of the one-off type of cases at this point in time.
And just looking at the chat, Tim, Jacqueline, any of you who are, currently rehabbing people either because of COVID or secondary, feel free to jump in. But Kevin, would you monitor, would you do things maybe that you wouldn't normally, like say check, pulse ox? You'd pull out your pulse ox when you wouldn't normally do that, or check heart rate intermittently throughout a session when you wouldn't necessarily do that with somebody without a history?
Well, I think it probably requires a little more context too, right? Because I think, the people that I've seen were either asymptomatic or presented very much just like a cold would be, like a, sore throat or something like that. So I think if it was maybe a little bit more of an at-risk population, I would say that might be different. But by the time that I'm seeing people at this point, A lot of it's just kind of just going based off of RPE and things like that. So in my mind, like if this person's coming in and they're sub 90%, with a pulse ox or something like that, they're probably either need to be monitored by somebody else, and hopefully they are already. But I have not seen a case come to me to where we were dealing with anything like that.
Anybody want to jump in?
Yeah, so I work in the collegiate setting. I work with athletes in return to play, and I've had close to about 10 in return to play through our setting. And one thing that we've kind of debated is the 14 days, 21 days, and really the biggest debate has become the EKG or ECG in return to play, and monitoring the cardiac rhythm. And what we found is we had one student athlete who all they had was a runny nose and a sore throat, and they actually developed pericarditis. And so that's where the EKG actually saved us in the return to play, because we then referred to cardio and did the workup there. In the asymptomatic scenario, we have still referred for cardio in the ECG, but a lot of people have just deferred that out, being that if they didn't create symptoms with the viral load, how much did it truly, affect the organ system? And so we kind of just monitor on return to play. The real debate becomes 7, 10, and 21 days, and how long to hold people out. And that's where the recommendations have become a little grayed. The Canadian Journal of Sports Medicine just released an article that's yet to be published. It's currently working through that process, but they actually just nixed that recommendation altogether and went close to 7 with no ECG in return to play, which was kind of interesting. In the German cardiology article, they found that like 70% age population was 45 to 70 had myochondritis post-COVID. So, I think the literature is coming to it, but we just don't have enough yet to make a true recommendation. And that was something I was kind of hoping to gather from you guys is what, when you're looking at these cases. I like the idea, of RPE as return to play guidelines, but when you're dealing with multiple systems and especially the heart, and when we know that athletes can really be affected by sudden cardiac death, that's a big concern as a clinician from my end.
Well, I think that's a really interesting parallel too, because there's been debate for a long time now with pre-participation examinations in terms of whether or not is it worth it from a cost perspective to have everyone go through ECGs. And from my understanding is they're kind of moving away from that now. I know I think Italy did a lot of it in terms of everybody was getting an ECG, but in the US now, a lot of the more recent recommendations, to my understanding, has been kind of moving away from that. So I think it's kind of fascinating to see how this is playing into where we're kind of going through the same sort of decision making and thought process, and determining whether or not that's something that should be pursued by anyone that has had any sort of contact with the virus or has acquired it.
And something that you had brought up, Kevin, earlier, and Jacqueline, this kind of goes with what you were talking about too. What's interesting is in that first paper, it's talking about the return to these guidelines that are so specific that obviously are not going to be a fit for everyone. And if there's one thing we have learned about COVID, it's that nobody has the same presentation. And even in a mild or asymptomatic cases, there can be these weird things that go on because it's so widespread and it's poorly understood at this point. But what I found most interesting, and I think this also parallels our conversation about concussion last week and this who manages what and when. The first paper is talking about recreational athletes returning to whatever it is that they want to do. And the guideline was 50% of previous intensity, and then that 50, 30, 20, 10. And it's okay, well, let's break that down for a second, because if you have a high level recreational athlete, their 50% volume and intensity is still going to be pretty high compared to the person who maybe is not at that higher level. And that 50% for them is going to be a little bit different. And so how do we break down, what are the things that we can look at to assess our individuals and say, okay, I feel comfortable making this recommendation with the overall or overarching recommendations that are out there from what people know that are smarter than me. And pulse ox I liked as one of them, because that's obviously an easy metric. And Kevin, you made this point, if they're under 90, I'm probably not the person that should be managing that.
Yeah, that's what's interesting to me too, is because the only thing that seems to be, for whatever reason, there seems to be, I mean, I'd imagine it's probably just due to sort of the latency of the virus being around like that 14-day mark. But looking across all this stuff, it seems to be like 14 days seems to be the thing that everybody has agreed on in terms of just, mandatory rest. And like, I don't know necessarily like where that number comes from per se. But it's interesting, like looking at like Lamar Jackson, like you mentioned, Quinn, where he was back on the field 12 days after being positive and symptomatic. And I would imagine that he was probably, doing the walkthroughs or something. Maybe he hadn't just showed up and just played, but I don't know. I think it's really hard to try to, like you mentioned, Alex, come to any sort of recommendation because the presentations are so variable. And, how many people that are in kind of like the younger age group are, going in and even being monitored by practitioners, like you said, like very little to none.
I had a client that, oops, sorry.
Go ahead.
You go.
No, I was just gonna say, I believe that number was coming from actually one of the papers. They talked from day 7 to day 14 is when the pulmonary cascade actually starts, right? And so that's really why they're waiting for that 14, is because you may not have the pneumonia or some of the other kind of things show up until that between 7 and 14 days. So they're wanting to wait that time frame to see if any of the pulmonary really starts to trigger off, because it's not happening in the first week. It's usually in between that first and second week. So they're just giving a little of that guideline for, we're going to wait and see if any of that really kicks off. If not, then okay, now we can start moving forward.
And so I was going to say, a friend of mine, she's one of our clients at the gym I work at. She's a professional boxer. She posted on Instagram. She was like, yes, first day back in the gym after COVID. And I was like, oh, hey, what's going on? So I asked her about it, and she ran like a hard 3 miles. She was 12 days out, didn't get seen by her doctor because her symptoms were pretty mild. She was feeling better. And she was like, oh, that's really, I sent her a couple papers, and she told me that one of the issues she was having was that she couldn't keep her heart rate at a normal level. And she was like, well, now that makes sense to me, but she had no idea. And it's like, okay, so like, if nothing else, the recommendation is please go consult a medical provider at minimum after a positive test and after this 10 to 14 day rest period. The other interesting thing, and I would love to hear other people who are going through this or have gone through this, so I've had 5 orthopedic surgeries, 4 knee surgeries, I had a hip surgery, I've had like other shoulder stuff, whatever. I have, over the past 14 days, I've had more like residual, just general pain from not being able to train the way I usually do than I've had in 10 years. And if I didn't know what I know, I'd probably be like, wow, this is new pain, I should do less. And so it's this like cyclical sedentary lifestyle is causing me to feel this way. But if I continue to be sedentary, I'm going to continue to feel this way. And if I, who trains 5+ days a week at a high intensity, feel this way, I can only imagine that anyone who doesn't do these things feels way worse. So what do I do?
Well, and I think too, the interesting thing is the isolation component, right? So if we separate isolation and quarantine, isolation being 10 days, you've been alone by yourself for 10 days. And that, there's also that mental component, which COVID affects both. And so, so it would be interesting to see as you start to return to training, how that all starts to wait its way out. But Kevin, to your point on Lamar and his, I think if you look at pro and you look at college and each pro team is doing something completely different. And intriguingly enough, we do have COVID groups working out, and we do have quarantine groups working out. And then we have the general population working out, and so it's been a fun thing to separate those things. And when you look at the high school setting and the youth sports setting, the hope would be that they hire a certified athletic trainer, or they have a team PT ready there to be a consultant. And, if there are coaches that this falls on, that they're prepared to tell parents to go to the doctor and get the clearance needed before the kids step back on the field.
That's really interesting to me, just because you have kind of like, you get the full spectrum there with like the multiple groups working out. Is there differences across like programming for the groups, like taking into account, there's probably differences in terms of like, certain sports are prioritizing different things based on the, the season cycle and things like that. How are you guys managing that in terms of, organizing programming or things like that? Are you looking to manipulate, session intensities or things like that, or kind of what's the thought process around there?
Yeah, so heart rate, max heart rate is what we're looking at. So like the COVID group is literally just shooting baskets or just hitting goals, or they're doing like very low activity. Just get them out of their room, get them moving, remind them of the sport, because in 10 days they could be back on the field ready to go. The quarantine group, it hasn't tested positive yet, and at the collegiate level and the professional level is tested daily. Like those guys are poor noses. They are testing on a daily basis. The collegiate level, the NCAA minimum is 2 to 3 times a week. Most schools are PCR or antigen 3 times a week. And so you're able to pull those positive kids maybe earlier, even before they start to be symptomatic. And so if there is exposure based on teams, so the Blake Bortles of the world who have been exposed, they will work out in a quarantine specific group. And then once test positive, move over to that COVID group to try to keep those people separate. And then obviously the people who haven't been exposed, and it becomes a full different game between an indoor sport versus an outdoor sport and the groups that you're working in. But then those kids that haven't been exposed work out at the same intensity within those groups accordingly. But if we're working in a COVID group, we do want it under, 60% of their max heart rate. So it's pretty low level stuff.
And is that the only metric that you're using to gauge the intensity of the workout?
It really does for us specifically become like what are doctors okay with? With those kids is like, okay, they said, yes, you can, shoot baskets and you get your own rebound and you have your own ball, or, you hit a goal and you have your own deal, but less of the general group.
Zita, go ahead and jump in.
Yeah, so I'm also in the college setting and just wanted to speak a little bit too. Like she said, the process looks different at every school. And interestingly enough, at our school, they have to be cleared. Every single player who would test positive does a 2-week quarantine and then goes through a series of tests, which includes stress tests, myocardial, EKG, everything you can think of. They hate it all. They hate being under all those tests. And then once they finish their quarantine, they come back and it happens in 3 days. So in 3 days, they're put through 3 workouts and 3 practice. And so the practices are graded back, whether it's non-contact first practice, non-contact second practice, or full contact second practice, but maybe half their normal player load. And then third practice is you're back in it. And that's after 2 weeks of nothing. And then their training with strength is 3 days of, interestingly enough, very high intensity work, high volume. It's a lot, and you could see it, and you could see the difference in players who, because our team was told if you are quarantining for 2 weeks, you are not to work out. You're supposed to stay in your room, clearly quarantine, but that would mean you have no access to any equipment either. You could see the difference in players who followed those guidelines and players who are more determined and in their room would make up their own body weight circuits or do something of the sort, especially if they didn't have symptoms. So we had kids that would come back to these return to play programming that included Olympic lifts, jumps, like everything you could think of, really putting them in the ringer, basically testing them to see, would you be ready for the intensity of a game? And there was people who made it through and played about 3 days later after their 2 weeks. And for example, we had one kid who, once the 2 other middle linebackers tested positive, he went from being a third string linebacker to playing every single defensive snap in a game. And he did fine. But then we had people who couldn't make it through day 1 of the program. So I thought it was interesting that itself almost, you wouldn't think, because especially reading this paper, it's like 50% reduced volume, then 40%, very gradual. But something like we talked about on our last call is when it comes to the pressure of college football, you kind of got to throw those out the window sometimes, because if your star running back needs to come back to play, he needs to come back to play. So definitely saw athletes being pushed to their limits. And we would monitor them. I mean, we had one kid who did, on day 1 of the program, had chest pain, so immediately stopped activity, and he was, met by the ATs and they took him from there. but definitely interesting to see how the exercise itself almost served as another screen of would you be ready to return to a game? Because if you can't make it through a workout, you probably can't make it through a game.
Does everybody get an ECG who
Yep.
tests positive?
Yep.
Have you had any come back abnormal?
No, we had one kid who had myocarditis unrelated to COVID, and was never able to return to play this year, but no, nothing from COVID itself.
And Jacqueline, to be clear, you right now, I know you guys are debating on the ECG for everyone, but are you doing that currently?
Yeah, everyone goes through an ECG clearance currently. And that's part of, like, everyone gets signed off by a doctor. The British Journal of Sports Medicine, who, Kevin, you made, Dr. Dresnick, who is out of the University of Washington, really big cardiologist. He was part of that publishing, and it's a 5-day return to play with a gradual increase that they publish. And it's really, really handy. But that's what we've kind of been following. They do kind of slowly increase over those days, but the ECG is a requirement. Asymptomatic doesn't matter. They got to get a doctor's clearance.
So when we're throwing out a question like, or a comment like, at minimum, you should go consult with your healthcare provider. We should probably specify what that actually means, because at the collegiate level, I'm not doing ECGs in my physical therapy clinic. What are your all's thoughts on maybe not collegiate, but the recreational athlete? We're recommending.
So I coach general population, mostly between like 20 and 70 years old. I've had probably, I think, 7 clients now with COVID, several asymptomatic colds, but I do have 2 long haulers. What I would say is that even other than the long haulers who have needed like severe interventions in the long term, no one else has been able to see even their regular doctor. Like, everything's so overloaded. So even, as a coach, like, I would much prefer if they went and had some sort of medical guidance to be able to give back to me, but they're kind of like, well, I made it and that's it. My husband's actually 12 days out and he won't see any doctor. Like, there's no plan for that.
That's exactly. So this is what sort of inspired me going down this route. Is I had a telehealth appointment with a physician at my PCP's practice. It wasn't my doctor, but I was like, I'll take anyone, I don't care. And I brought up the prospect of getting an ECG because I participate in high intensity exercise. And she was like, but do you have chest pain? And I was like, well, I did have chest pain. And so I had to advocate for why this was important. And so that is, Quinn, I think that's a great question, because I think it ends up falling on us, and whoever just spoke, I'm sorry, I don't know who it was because I didn't see you, but that's exactly what I've seen, is that we end up being a little bit responsible in the sense of how do I'm a little bit in the role of having to help these people make decisions. I'm not qualified to make the decisions, but I can help guide them through the process. And Kevin, you brought this up earlier, appropriate exercise prescription, and taking it back to like, what is the physiology behind the cardiovascular system and cardiopulmonary system, and how can I use that knowledge to make better recommendations than maybe what they're going to choose on their own, because they maybe can't get an ECG from their.
Right, but part of this is also we're extrapolating from, even if you look at the articles, all the data is really on hospitalized individuals. And then we're trying to do this in non-hospitalized individuals, and we really don't know what that data is. So even the healthcare provider is going to go, well, I really don't know what the guidance is here because you weren't hospitalized or you were asymptomatic or mild symptoms. And so we really don't have any guidance here. We can extrapolate from what's been hospitalized, but now are we having a cost overrun and we're over medicalizing something that may or may not need that, right? And so we really don't know because everything is extrapolated just from these hospitalized patients, because we don't have good data tracing and some of that other stuff on people that aren't seeking medical care and aren't doing all that kind of stuff. And so they're in a quandary as well. I mean, we're looking at the literature and going, what the hell did we say? I think they're doing the same thing.
Yeah, I mean, that's kind of my concern, but I think it really comes back to just kind of cover your ass type of thing more than anything. Like, it's why we're kind of really going down, getting an echocardiogram for somebody that was, asymptomatic or, very mild symptoms. Like, it seems like a huge overstep, but just the degree of the uncertainty surrounding it and, the hyperbole, whatever you want to call it, I think that's really what it's more probably a manifestation of than anything is people don't know what to do. So let's just take an abundance of caution here. And at least we said that we jumped through all the hoops that we needed to.
Right. But then if they were taking one of the quinolones or one of these other drugs that's going to have a depressed QT wave and that doctor doesn't really know, now what are we going to do? Right. I mean, this really is kind of an interesting conundrum we just don't have enough data. Right. So we're making recommendations on people and there's really not good data to drive that. So again, basic physiologic understanding. And as we go back to it, almost falls back to, okay, so how do you feel? What are we looking for? What signs can we monitor that are going to give us indications of cardiovascular health or other whatever systems we're doing? This may be multiple systems. They may clot and they may throw a clot. Shit, what are we doing that's going to do that? How are we going to prevent that, right? There's so many things that it may or may not involve. We can't screen all of that. We just have to be monitoring like we would with anybody else, because the reality is my mom had a 7-inch clot in her calf. And it was asymptomatic, no pain, no nothing. It was tested. She was doing some blood testing and they actually went, holy shit. All right. You need to be on some drugs and you need to have some other stuff. Right. I mean, so shit happens. Right. So even just in the general population, weird things are going to happen. It may just be one of those kind of things that we need to mitigate what risk we can, but do we know how to do that well when we're extrapolating from all these other data points that aren't necessarily the clientele that we're seeing?
But then also on that same point, are we like, I think about the people that then are going back to exercise and haven't seen a doctor, they're previously healthy. There's no reason that they would go down this route and they're feeling better. But as we know, as some of the COVID-19 presentation, especially a little bit down the road, is that like residual shortness of breath, which can also be deconditioning that they're feeling. And they're like, oh, I can just push through this because these people that are trying to return to activity. And that's where I'm like, as a coach, I want to say, okay, let me at least make you aware of some of the things and you make a decision about whether you're in a position where you really want to chase this down or you're comfortable doing what you're doing, but know that this isn't just like you're going to feel shitty for a couple days. Like this could have a greater implication.
Tim, go ahead and jump in.
Woo, 20 minutes, man. Dang, that was a good combo, guys. So I'm hearing a lot of really, really good points. And I think this is one thing that I feel like everyone, I guess maybe not here, just in the world is feeling. And it's a sense of fear of really not knowing what to do. And in this type of situation, I would have to disagree with some points here that there isn't data. Go back to the bread and butter of all viral infections, of all getting sick and what to do when we want to go to the gym and we're sick. There's a good amount of information. A couple of them are from, a good one is Lyle McDonald's. The guy is one of the big meccas of the workout gurus in the world. One big thing is, below the neck, a lower respiratory infection, you want to stay home. That's what one of these articles kind of recommends. If you're contagious, stay home from the gym. So we kind of have that down right there. A couple other information is that shows that moderate intensity exercises actually improve respiratory function as well as it improves immune systems. So I guess what I'm trying to say is that I think with the word COVID and when we're working with people like that, we're scared because we really don't know what to assess. But Alex, Paul, Kevin, everyone, you guys said it best. Every time we see these people, we're always assessing. And that's our bread and butter, to always assess how you're feeling today. How can we make today better than yesterday? And I think that's the home run that we should really focus on the most with all patients in general, and especially with COVID patients. To get away from that field, assess, do the best you can, and that's really it.
Jordan mentioned something interesting. Our lab, so back to kind of down the nitty-gritty of assessment, Are lab values coming into play at all for those who are extensively testing? Or is that more of a kind of a secondary analysis, just as the inflammatory response goes down, those lab values start to normalize, and those aren't necessarily a metric that you're looking at specifically?
We're not taking blood work on people here.
Okay.
Yeah, I think blood work specifically for us is the people who have biochondritis confirmed, and we're doing tryptomycin, that sort of stuff. But otherwise, no blood work for us as well.
I say let's hop into the breakouts. Megan has prepared some incredible prompts for us. I'm going to throw those in the chat. So we're gonna break out into our rooms, and we do this to make the conversation even more direct and intimate, and be able to have these discussions. So if you don't want to join the breakout rooms, if you're not feeling that, that's totally fine. But go ahead and just peace out now, so that when we break out, the rooms can be even, and then you'll get the recording afterwards, so you won't miss anything, and you can watch what you miss. So there's always good conversation after breakout rooms, but I would encourage you to stick around. And it's always a good time, and the breakout rooms have been really, really successful. So the prompts are in the chat. There's 3 of them. Don't feel pressure to get to all 3. Just, let the conversation guide you, but those are there to kind of guide the ship. And I'm going to do this and a little of that and a little of this, and then magic. Did I interrupt some good conversation? I hope I did.
Epic conversations, man.
Always.
Good. That's why I do it. So who's got some awesome things to share?
I think what Paul and I were talking about in our discussion session is, this is, the gift and the curse of medicine, right? There's such a huge spectrum of what to do. Everyone's affected differently. It's not like it's 2 + 2 is 4, So I think we fall into this cataclysmic event of, well, I'm doing this and they're doing this and this one's doing this and this and doing that. And we're all trying to figure out what the best way of doing it is. And in general, there really is no best way of doing it, right? It's your best way of judgment through assessing through multiple sessions with a person. That's what your best is. There isn't the best, it's your best that you're giving. And I think that's tough for medicine. And as with, what we see with COVID and fear that this is putting into a lot of people, we're in this debacle right now. It's hard to assess.
There is a lot of uncertainty around all of this.
Yeah, we had a point kind of brought up about just kind of with like primary care providers or like other healthcare providers being at their capacity and not being able to see these patients. Maybe that creates more of a space for physical therapists, athletic trainers. I think Alex said educated strength and conditioning coaches. And just kind of as resources to progress these people back. And then we also started off on a tangent talking about wearables. So I don't know if Alex, you want to jump in there?
We just talked about like the utility of this is an opportunity for you to, or us as clinicians, coaches, to leverage people's wearable technology to help them make better decisions for themselves. So for example, my Whoop, typically, which is a wearable, if you're not familiar, that tracks HRV, sleep, recovery, strain, et cetera, a variety of different things. And also recently started tracking COVID symptoms. And I noticed the day that I tested positive, which was also the day that I had the worst chest pain that I've ever experienced in my life, the only chest pain I think I've ever experienced in my life. My respiratory rate, which is typically at a 14 and very stable, was at a 17.5. And so if I hadn't gotten tested for COVID, I could have gone into my Whoop and been like, huh, this is interesting. That's never been like that. My Whoop once told me that if that changed, I should probably consider the possibility that I have COVID. And so that's an opportunity. Apple Watch, Aura Ring, Whoop, whatever other ones that you have out there. It's just an interesting metric to say, hey, have you noticed anything different about your data?
I muted myself. I was kind of getting to the question. Yeah, I'm good. Figured it out. I posed before our breakouts in regards to what type of healthcare provider are we actually referring people to? And that's an interesting point, that if our primary care physicians are swamped and these COVID patients are not actually able to see them, and allied health professionals become maybe next in line. Let's say these clients or athletes or people don't have wearables. Are we doing specific physiological testing? Is that where pulse ox comes in? And are we paying more attention to vitals and respiratory rate during exercise, where we wouldn't necessarily be monitoring those in our cases? That's what kind of the question I was getting at earlier. Or is it still, the downside is, as bad as these complications are, it's so rare that it doesn't necessarily change what we do beyond what we normally do, which is graded exercise prescription and just kind of monitoring their subjectivity across that time. Do you guys have any thoughts on that?
Quinn, I'm going to give you $1 million idea right now. You ready for this? This is good. How you become a billionaire. I want you to
a millionaire or a billionaire? Because you said
you know what? As high as you want. Okay. As high as you want, Quinn.
All right.
I want you to create, because this will be perfect for the answer to your question. Create almost like a C-spine rule for COVID symptoms, right? Do it like one of those tree diagrams that the C-spine has. Do you have shortness of breath? Yes, you go here. No, you don't need to go to the doctors. If yes, okay. Is your respiratory rate above this or that? Yes, okay. Then you need to go to the doctors. No, take 2 weeks off. I think that would be a perfect thing for COVID, a C-spine rule type thing to just go monitor through symptoms to see how severe they are. And judging upon that severity, go to the doctors or not. There's your billionaire idea right there. Boom.
I think that's actually included in the HSS recommendations, is this like nice flow chart looking thing. There are, I think, 2 other research groups that put, or 2 other organizations that put something similar out that looks like that. I think the funky part is that it's like, there is no direct, these people maybe aren't getting into their provider because they can't. And so if they don't have someone who's telling them, hey, I have this really nice flow chart that tells me what to do, they sort of just go back to what they were doing before.
Jordan, go ahead.
I think in the end, like in its real most simplistic level, it just adds another level to like our review of systems. But at the end of the day, it's this back and forth with your athlete or your patient going, you can give them all the information, whether it's fully available or not. And it's like trying to convince either them, like, hey, these are the risks and this is what I think you should do. But in the end, you're going to have to make this decision. And I feel like there's just not enough of a push for the general recreational athlete of these huge risks and, these one occurrences that happening, because it's a possibility, even though they don't happen enough to scare a lot of people. It should just kind of be part of like our review of systems of like, hey, this could happen. Here's my recommendation. We can go from here. And that could be applied to like any past medical history, or pre-existing condition. It just is so tough because we're in this situation, because there's not enough data. And I think that's like the toughest part about this. In the end, we can do as much as we want, and we want to, because that's why we're in this job. I just don't know, like, exact, Tony, see, when do we draw the line? Like, I don't know. I have no idea.
This had been brought up. Oh, sorry, Kevin, you go.
I think so. This discussion is interesting to me because, like, probably like number one killer of Americans is, you know, some sort of cardiovascular disease or heart disease. But meanwhile, we can't even get people to screen blood pressure for the most part as physical therapists. So it's just funny to see how, like, because COVID's kind of like in the spotlight, like now we're having these same discussions. But when in reality, like, if we're concerned about, you know, potential adverse effects from exercise, like, we should all be monitoring blood pressure and going through like a, you know, a cardiovascular history like pretty extensively with people. So I think ultimately, Quinn, kind of to answer your question, like I still kind of fall into the camp of like the latter portion that you said, where we're just, you know, we're making appropriate recommendations and being smart with exercise prescription. Because I don't feel like we have enough information at this time to really go much further beyond that, because the presentation is so variable. And I'd imagine, you know, recommendations from just the healthcare in general will probably change as more information comes out. But until that time, just being smart with your exercise prescription and being able to maintain some sort of fluidity in the plan of care is probably the best thing. I think we can probably go maybe too far in the wrong direction if we are over screening to a certain degree.
I would agree, but we got to have basics. I mean, if we're monitoring the basic heart rate, we're monitoring that. I don't typically do that through a course. My session RPE or some other metric is what I'm using for my general pop, right? I mean, I may start, but if somebody has blood pressure issues, has one of these cardiac factors, right now I may be monitoring that. Well, post-COVID, now I'm just monitoring that through. I've got 4 that I'm seeing right now. So I'm monitoring those things in a different way than I normally would with somebody who, okay, we've shown exercise tolerance. I'm not going to continue to monitor that. We're just going to see how well you're rating these exercise programs, right? So there's a slight difference there. The hardest part though is, okay, Alex knew that she was at a 14 and 17.5 was odd for her. Most of my clients have not a damn clue what their breathing rate is, right? And so I have no baseline data to go from. So, okay, you showed up at a 16.5 for me, but what's a good rate? What's a good thing? How far can I push? Because we don't have any baseline that they really know. Because how often do you breathe? Shit, I don't know. When I need to, right? I mean, so some of that data is just, they're not going to have those things unless they're people that are already engaged heavily in exercise and are doing some of those kind of things. So we can monitor, and I think that we should monitor a little bit more, possibly some of those cardiopulmonary factors within exercise for those that have been diagnosed and are going through. But, you know, but some of those points are, we don't have good pre-data. So where are my cutoff points for these individuals, right? Like Tony's question. So at what point when they're breathing at 19, do I send them to somebody, right? I mean, you know, we have pulse ox. If they're below 90, maybe I don't need to be managing that. I need to be having somebody else deal that. But we don't have on some of these things really hard and fast rules. We have basically where they were before and where they are now. And if we don't know where they were before, where do I go?
But I think we do have like baseline metrics of what's a healthy blood pressure. And that, Kevin, that's the exact point that I was getting at. I was going to say the same thing, like Michael Amato, and I know like Melanie Hudson have been extensively having this conversation about screening blood pressure as a baseline metric for every physical therapy patient. And Paul, to your point, you're right. We don't have these, we might not have something to compare it to. However, what I imagine, and I think is what I've seen a little bit, is that some of these patients that you see in an outpatient orthopedic setting, they likely, many of them are not also seeing their PCP regularly, and they're seeing you because there's something that has now impacted their quality of life today, that maybe an ankle sprain, a knee injury, whatever it is, that's getting them in your door, but they didn't go see a cardiologist or their PCP to have those vital signs screened. So I think it's like basic vitals and then COVID related vitals. If someone tells me they previously had COVID, I might assess respiratory rate, pulse ox, etc. But as a baseline, when I graduate, I'm going to check blood pressure in everyone.
That's the point that I was making, is like, let's start with like kind of some of the low hanging fruit first to make sure that we're doing that before we kind of drive ourselves crazy here with, you know, asking about their most recent ECG or something like that. So like, let's hit the basics first.
That's such a low hanging fruit that even I can reach it. I'm short.
It's a joke because he's short. Okay, yeah.
I was about to say I'd have to bend down to reach it, but he already beat me to the short jokes.
I guess last thing, what do you guys think about the 50, 40, 30, 10 graded exercise prescription? My thought was it's just they're giving somebody something. To me, all that means is it's a model that, hey, you should probably start conservative and incrementally creep up. And it was every week. So in my mind, that at least tells me, oh, maybe it shouldn't be every day. Like Azita was talking about with their 3-day protocol, which is not, that's not her protocol. That's just, it is what it is. But to me, if it's not exactly 50, because what exactly 50 of what? Because a lot of these athletes are doing different types of things. So it's hard to measure exactly what 50% is, but start conservative, start with something that they could have done on their sickest day, if you really want to be conservative, and see how they did with it. And maybe just repeat that a couple times that week, see how they do. And then if they are good with that, do a little bit more the next week. So I don't think it has to be anything groundbreaking.
Yeah, I used that with my son when I was returning him from his COVID, right? And I didn't do the 50, 40, 20, 30, 10, whatever. I mean, that just seemed a little bit drawn out. We started, he tracks everything, right? Because he's lifter and does everything. So we took him back, and how'd that feel? Well, that was pretty damn easy. Okay, well, let's move that up a little bit. Okay. And so we probably went from 50 to 35, right? Okay, well, okay, that actually didn't feel too bad. Okay, let's go to 25. But when we got around that 10 to 15% mark, he was feeling tired, more tired than he normally does, right? Okay, so we need to hang out, back down and hang out here a little while before we start moving that up. So it's really kind of finding where that limit is, where you're starting to go, okay, yeah, that's starting to bother me a little bit. Okay, we'll back off a little bit and then live there a little bit. But right, it's just basically general guideline of let's start conservative and kind of move up. They're going to put hard figures on it just so that they have a number methodology, but really it's kind of going by feel. Let's back off to a certain degree and then see what does that feel like, and then slowly move it up. And then it's just exercise prescription, right? I mean, okay, where's our tolerance? And then we're going to live here a little bit until we get a little tolerance to that and progress it on. But he ran into a wall where his endurance and his fatigue afterwards was real, and we had to back that down and give him a little more time.
Going off of that, I feel like one tangible thing to take into the clinic is looking at rest ratios, because this isn't a time where we're going to be pushing people on their work to rest ratios and try to get cardiovascular effects, or are we doing a circuit? Even with college athletes, if they ask for a rest break, you're giving them the rest break. There's no, let's push through it. If you feel winded, let's absolutely take a rest break. So I think that's one thing to take into the clinic, is really take advantage of a full rest break. We're not trying to push these people. We're just trying to slowly get them back into activity. And that's, to me, to answer your question, I think the 50, 40, 30, 20 is fine, because at this point, I think we're more worried about what Kevin said, covering our asses. I'm not here to push people on volume and intensity of their lifts. I want to get you back into physical activity after 2 weeks of bed rest. And if that means taking a long rest break between sets, that is okay with me personally.
Yeah. And one of the papers mentioned it like in passing, but appetite and nutrition and calories, not only are a lot of these athletes taking 2 weeks completely off, but if they were symptomatic, maybe they couldn't taste, they couldn't smell, they were nauseous, or, they probably lost their appetite. So they probably lost some weight there too. And so now you're coming back, not malnutrition and you're underfed, you're undertrained, you're already just recovering from a viral infection. So it's a lot of confounders there that can manifest. So yeah, I think that was just another piece of, ask them, how's your nutrition, how's your calorie intake? Are you eating as much now as you were before you got sick? And if the answer is no, that's another point of emphasis. Maybe we start bumping up your food intake a little bit, make sure you're getting enough fuel, because that's only going to help our cause when it comes to getting you back into shape.
One interesting thing I came across and I can't remember if it was in the papers that we had read or if it was in the HSS recommendation, but they talked about resuming resistance exercise before cardiovascular training. And that's a strategy that I am putting in place with myself, because I typically compete in powerlifting, but I keep my rest breaks pretty short unless I'm pretty close to a peak, because I'm trying to increase my aerobic capacity. Right now, I'm taking me upwards of 2 minutes between sets so I feel like I'm a bodybuilder right now. And I'm actually going away from compound exercises and doing more bodybuilding type exercises because it gets me in the gym. It allows me to train at a moderate intensity. It allows me to manage my heart rate. And I think that's kind of interesting that that recommendation was in the HSS paper, and sort of in passing, similar to the nutrition item. But that's something to kind of think about, that we can actually, there's a low hanging fruit there to integrate people back into that aspect before cardiovascular conditioning.
There's probably some other powerlifters on this call that heard your 2-minute rest break and they're like, wow, you're doing CrossFit?
I would
And
say
you're
that's
like,
pretty fast.
Yeah,
No,
well, I'm a soccer player, rugby
it's all
player,
relative. Yeah.
powerlifter, so.
Your 50% is your 50%. No, that's a really good point. You know, what can we do? Maybe we can't do it all at once, but what can we start with? And there's going to be a small cardiorespiratory response with resistance training when you manipulate rest periods, just more activity. Again, after not doing anything for 2 weeks, you get under the bar for the first time again, and you're probably going to be huffing and puffing. And you know,
It's happening.
Yeah, if your heart rate starts going faster, well, you're training your cardiorespiratory system. So
When that happens, just when I walk in the gym, I don't have to be under the bar yet, you know.
I hear you, man. My heart's going now just thinking about it. Oh, Joseph, do you want to just talk?
Sure, why not, Quinn? For you.
Thank you, man.
I'm just going to read what I said.
Okay.
So I'm a home health physical therapist. So I usually take vitals after physical bouts with my patients. I do it multiple times. So the reason I do this is it kind of gives me an idea of where they're at in terms of their work capacity, their ability to recover from whatever I just have them do. And it kind of guides me for that current session at the very least on how much to push or pull back. So I've had patients where like their oxygen just kind of drops down to 80. I'm like, all right, let's chill out for a bit, you know? And so, but the tricky part about that is that some of these patients, they have a lot of stuff going on with them, kind of like a sequela of whether being bedbound or inactive or whatever other medical complications they developed during this time period. And so medication changes can occur, new onset of whatever. And so it's tricky doing it that way just because not all the patients present the same way as they did previously. And I mean, we all know that training is not linear in itself. And so it's kind of like navigating on a per session basis.
Mm. Yeah. It sounds like that's kind of the common theme is you're just taking gathering as much prior information as you can on the person, where they were before you started working with them, before their diagnosis, what they were doing, their medical history, your notions of possible complications and risk of complications and all that. And then again, addressing their response, individual response in the moment compared to your prior knowledge, you know, which is what we do anyway. But first of all, I love the fact that you've got a barbell and rack behind you. It's just very fitting for the conversation. Yeah. Tony just dropped something, and thanks for that, Joseph. Appreciate that. Tony dropped something in the chat on a paper in which they don't recommend ECG, cardiac MRI before return to play. Okay, so if they have cardiac symptoms, work them up. If they don't, then don't. But which is probably what I would imagine in a year or two is probably going to be the recommendations, recommendations, kind of bringing it back to where we are now, which is if you have cardiac symptoms and get a workup. If you don't, then don't. But like Kevin and all you are saying, like, because of the uncertainty, because of the old, like, cover your ass mentality right now of so much we don't know, everybody's getting worked up if you test positive. I don't blame the powers that be for that process when it comes to governing bodies that are managing a lot of moving parts, universities, pro teams, when there's a lot of skin in the game, a lot of stakeholders, and a lot is at stake. I get it. Anything else to add, anybody? This was a pretty good one. This was a really good one. I've got a couple things to part with. Next week, we're on a hiatus because we have organized, Taylor, Alan Flanick, and Derek Bark, who's with us tonight, have helped to organize a case study. And I'm going to put, it's free. I'm going to put the link to the Zoom link in the chat. It's Dr. Jacob Harden and Aaron Kabul, and I hope I'm not mispronouncing his last name, but those two are going to be doing a case study, and it's a chiropractic case study, but don't let that fool you. It's open to it's going to be relevant and to any healthcare professional. We are just, we're on kind of a mission to show that the titles don't mean a whole lot. Chiropractic, physical therapy, athletic trainer, we're all just trying to abide by the same principles. And so that's why we're making this initiative. But no matter who you are, that's going to be a really awesome, valuable event. It's going to be pretty cool to see two awesome clinicians talking through a case together. And it'll be like this, but with a specific case. And then if you hadn't heard, Clinical Athlete and Level Up are joining forces, making CALU even more of a powerful entity. And if you haven't yet joined what is now the Level Up Facebook group, will be soon the CALU Facebook group. I just dropped that link in the chat too, and that's a free group. And so request to join ASAP, because we're going to be doing some really awesome stuff. So we will, I never know how to end these things. Thanks, everyone. Thanks, Kevin. Thanks, Megan, for organizing. Thank you, everyone, for participating. This was really, really great. I feel more confident. If I have somebody post-COVID on my caseload on Monday, we'll feel more confident addressing their needs because of this meeting. So I want to thank everybody for that. And we will see you next time. Piano outros soon. I play every day. I practice every day. Soon. So my fingers freeze up when people watch me. It's crazy. All right. We'll talk soon, everyone.
Yes.
Good night.